About 1 in every 10 strokes that we see turns out to be an intracerebral hemorrhage, and it's got the worst outcomes of all stroke subtypes. For every 10 patients that we admit, about 3 are expected to die during their hospital admission, and of those that remain, about 5 are discharged with either moderate or severe disability. The aim of our project is to reduce death and disability after intracerebral hemorrhage by about 10%. And you can help us achieve this by focusing on the ABCs of intracerebral hemorrhage, and A stands for anticoagulant reversal. At the moment, we expect about 1 in 10 of our intracerebral hemorrhage patients to be taking an anticoagulant. But importantly, you won't know if they are unless you remember to ask. So for all our patients, ask whether they're taking warfarin, and don't forget the newer anticoagulants. For patients on warfarin, you need to give Beriplex as quickly as possible and no later than 90 minutes after admission, and for patients on the newer anticoagulants, discuss every case with the haematologist on call. Next up is B for blood pressure lowering, and whilst all intracerebral hemorrhage patients benefit from good blood pressure control in the long term, we know from recent evidence that intensive blood pressure lowering is of benefit to selected patients. Patients who arrive with a clear onset time that's within 6 hours of presentation to hospital and with a systolic blood pressure over 150 millimeters of mercury are eligible for intensive treatment, and it's important that it started as soon as possible. For these patients, you should be aiming to lower the systolic blood pressure to 140 millimeters of mercury as soon as possible and no later than an hour after starting treatment. The first line treatment is a GTN infusion for 30 minutes, followed by labetalol boluses for a further 30 minutes, and if your target's still not been achieved, you should seek help from the critical care team. And finally, C stands for care pathway, and all patients who present with a GCS less than 9 or high-risk features such as posterior fossa bleeds, large volume hemorrhages or obstruction of the ventricular system should be referred on to critical care and neurosurgery for further assessment. Overall, we expect about 2 to 3 of our patients to be eligible for this high-risk part of the pathway. All other patients will be suitable for care on the acute stroke unit. And finally, it's really important to remember that all of these interventions that we need to give are time sensitive and work best if they're given as quickly as possible. So until you scan patients, you're in the dark as to whether or not they've got an intracerebral hemorrhage. So get them off to the CT scanner as soon as possible, get that scan done, and then we can pick out the intracerebral hemorrhage patients from all the other ischemic stroke patients and non-stroke patients that we see in our service. So there you have it. Always remember ABC, and together we can improve the outcomes for patients after intracerebral hemorrhage.